Hello doctors, welcome back to Jab Studies Made Fun for Medicine Part 16. In this topic, we're going to discuss about the adrenal gland, the different disorders associated with the adrenal gland and much more. It is a very high yielding topic, so make sure you understand each and every line of this topic, okay? So without further ado, let's start. The first thing what you guys need to know is the shape of the adrenal gland. The shape of the adrenal gland, the right side is a triangular shape, while as the left sided adrenal gland is a crescentic or a semi-lunar shape. So please remember this, that the right side is a triangular shape, while as the left side is a semi-lunar shaped. Now if you talk about the layers of the adrenal gland is divided into two parts, a larger cortex and a medulla. In the cortex, you have three layers, that is G, F, R. Outermost is going to be G, innermost is going to be the R. Where GFR, where G stands for glomerulosa. The glomerulosa is responsible for secreting aldosterone. Now, what is the function of aldosterone? Make sure you understand this slide very importantly, because all the disease which we are going to talk about after this is going to be related to this mechanism. So, the glomerulosa is responsible for secreting aldosterone. The main role of aldosterone is to maintain the postural adjustment of the blood pressure. Now, what does aldosterone do is, now aldosterone is responsible for controlling the blood pressure, and how does it do is that the aldosterone is going to go act in the INAC channels over here, the INAC channels, and what this INAC channels do is, we have discussed this earlier, the INAC channels takes in salt and water. Wherever salt goes, water follows, and vice versa. So salt and water comes into the body, which means reabsorbed in the exchange of potassium and hydrogen. Now, because if this is, see, whenever it is required in acute condition, it is good. But if this happens for a chronic time, you will notice one thing, that the potassium is depleting, due to which the patient will suffer from hypokalemia. And hydrogen also, which is an acid, is also going, because of which you will have suffering of metabolic alkalosis. So patient will be thereby suffer from hypokalemic metabolic alkalosis if this process goes along and long and long. So remember, first of all, glomerulosa, that is aldosterone. Aldosterone is responsible for activating the INAC channels. Thereby, water and salt is coming in the exchange of your potassium and hydrogen. Next is fasciculata. Fasciculata is responsible for producing cortisol. Now, cortisol, as you all know, it is a stress hormone, along with which cortisol also regulates sugar. If there is too much cortisol, there is too much sugar, thereby there will be hyperglycemia. In conditions which is known as your adrenal insufficiency, where there is lack of production from the fasciculata, which means cortisol will be less. So if cortisol is less, thereby the patient can suffer from hypoglycemia. And what are the symptoms of hypoglycemia? Irritated, sweating, palpitations will be there. Like, these are the symptoms which you will see. The third layer which you need to know is reticularis. Reticularis is going to produce your androgens, that is dihydroepiandrogen diones, like that. Multiple things will be there. Now, androgens are responsible for multiple things, okay? If it is responsible for maintaining your development of your pubic hair, axillary hair, voice, and much more. If this is absent, if DHEA is absent in cases of adrenal insufficiency, you will see axillary, pubic hair and all, they will be going, okay? These are the three parts within the cortex. The next part is medulla. In the medulla, you have catecholamine secretions. Now, what are catecholamines? They are dopamine, epinephrine, and norepinephrine. Now, they will give you a question, fight or flight response. First of all, fight or flight response is what type of, it is a sympathetic or parasympathetic? It is very good, sympathetic. Which the catecholamine is responsible for the fight and flight? Answer, if they have to ask you one, you have to mark epinephrine. Remember, where do you use as a drug norepinephrine? Conditions like septic shock, over there you are going to use norepinephrine as the drug of choice. Rest and digest, that is maintained by the parasympathetic system. So with this details, I have talked about the deficiencies, I talked about the mechanism. With this, now let us talk about the abnormalities associated with the adrenal gland. The first one which you need to know is pheochromocytoma. Pheochromocytoma, if you notice one thing, in pheochromocytoma, chromo comes. Right, so if chroma is there, it is also known as chromophenoma. It is also known as chromophenoma. This is a PYQ. Now, what is this basically? This is basically a tumor of the adrenal gland. Specifically, it goes and attacks the medulla. In the medulla, you'll have this cells which is known as NCC, that is the neurocrescentric cells. Over there, a tumor begins to develop, because of which it now starts secreting more catecholamines. They will ask you which catecholamine is secreted more. You have to mark norepinephrine over epinephrine over dopamine. Okay, pheochromocytoma has a classic feature, that is the 10% rule. We'll talk about the 10% rule together in the next slide, but now let us understand a few of them. First of all, it is 10% malignant, which means 90% is benign. To differentiate between benign and malignant, you have to do a scan, that is the MRI abdomen. Now the problem with MRI abdomen is, if the size of the tumor is less than 1 centimeter or less than 10 mm, this MRI will show a normal result, which is a false negative. For which the next method you have to do is you have to use a PET DOPA or a MIBG scan. Now what you have to know is that 10% is malignant. 10% can be formed extra adrenal. Now, which I told you is usually it will be present in the medulla. 10% of the chances are there where this will be not in the medulla, it can be in the sympathetic chain, and that area is known as organ of Zuckerkandl. That area is known as organ of Zuckerkandl. 10% are seen bilateral in both of the adrenal glands. As I told you, to differentiate between benign and malignant, you have to use MRI abdomen. But if the size is less than 1 centimeter or less than 10 mm, it is basically useless. The next investigation you have to do is a PET DOPA. As you know, PET DOPA, positron emission tomography. This scan is basically used to detect distant metastasis. So you can use this. Another specific test, if you ask for pheochromocytoma, is MIBG scan. You need to know the full form, that is methyl iodobenyl guanidine. So basically, understand this is the algorithm for the text. Along with this, 10% of pheochromocytoma is associated with MEN2 syndrome. Now there are basically 3 types, MEN1, MEN2A, MEN2B. MEN2B is also known as MEN3. Just to talk about superficially, we will talk about MEN in another lecture. But remember, in MEN2, which is seen in pheochromocytoma, it is also known as Sippel syndrome. Okay, it has association with red gene, which is present in the chromosome number 10. Now, what are the tumors associated with MEN? MEN is multiple endocrine neoplasia. So there are multiple tumors which can be seen. In MEN2 over here, you will see 3, which is PPM. That is going to be a parathyroid tumor. Another one is pheochromocytoma. And M stands for medullary thyroid carcinoma. Make sure you understood. So remember, MEN2 is also known as Sippels. The gene is red gene and the chromosome is chromosome number 10. So as I told you, this is the rule of 10. 10% malignant, 10% are found in the sympathetic chain, that is known as organ of Zuckerkandl, 10% bilateral, 10% extra-adrenal, and 10% of the cases are associated with MEN2. There is another rule in the medicine, that is rule of 9, which is seen in burns. And please comment below, where do you see rule of 2? It is a hint, it is usually seen in children, and it is a topic which is discussed in surgery. What are the clinical features of pheochromocytoma? Now, as I told you, catecholamines, right? So in catecholamines, norepinephrine and all, they are responsible mostly for acting on receptors which are involved in blood pressure maintenance. So one thing what you will have is the clinical features, you can remember it with the mnemonic of PHD, where P is going to be palpitations. Okay, H over here is going to be headache. The reason of headache is going to be because the patient has, sudden bouts of hypertension, and D is diaphoresis, which is sweating. So remember, PHD, palpitation, headache, hypertension, and diaphoresis. Now the palpitation wala thing, or the heart rate irregularities, is because of the beta 1 receptor. On the other hand, the hypertension is associated with the alpha 1 receptor. Now why this is important? Because we are going to give drugs which is going to control these symptoms. So if you talk about what is the workup, as I told you, pheochromocytoma affects the medulla, and the medulla has catecholamines. So we are going to test the level of catecholamines, specifically norepinephrine, right? So 24 hours urinary metanephrines, 24 hours urinary catecholamines, 24 hours urinary, this is the previous year question, vindyl maladic acid as well. Now remember this, that this is the screening test. Now, one thing I want to tell you is that why that in pheochromocytoma that there is paroxysmal, which is means for a short duration and then it goes away, hypertension. The reason is because the main, the tumor secretes maximum norepinephrine, and norepinephrine as compared to the 3 catecholamine has the shortest half-life. So that is why it comes, it goes, it comes and it goes. That is why patient has, interval type episodes. So the investigation of choice to find exact amount and to find the diagnosis is plasma fractionated metanephrine. Plasma fractionated metanephrine. So as I told you, this is the further algorithm. And now let us talk about the treatment. So the main thing which we need to treat over here in pheochromocytoma is hypertension, to prevent anything of hypertensive crisis or urgency, right? So what you have to do is, for the hypertension, we are going to give a non-selective alpha blocker that is known as phenoxybenzamine. Phenoxybenzamine. For the tremors and the palpitation which are acting by the beta receptor, so we are going to give a beta blocker, that is propranolol. Now, a very important condition and a very important PYQ is, what do you give first? Do you give the alpha blocker first or beta blocker first? you always have to give the alpha blocker first and then you have to give the beta blocker. There is a reason why. Because the alpha is responsible for reducing the chances of hypertensive crisis. The beta blockers are just responsible to control the heart, which is tremors and palpitation in male. If by chance I am going to give a beta blocker first and later on I give an alpha blocker, there is unopposed alpha action, because of which there is vasoconstriction and then there will be a hypertensive crisis. The hypertensive crisis can further lead to pulmonary edema as well. That is why always remember, whenever you are having a patient of pheochromocytoma, and before surgery, the management of choice is always first you have to give an alpha blocker, phenoxybenzamine, a non-selective alpha blocker, after which only after breakfast you are going to give a beta blocker. If during the operation or you will have a sudden spike of hypertension, increase in blood pressure. Why? Because obviously you are handling the adrenal gland. It is a very sensitive organ, or there's might secretion of norepinephrine or epinephrine will cause a spike of blood pressure. In those conditions, now you will not use phenoxybenzamine. Over here you are going to use the intravenous route for sodium nitroprusside. Okay, for sodium nitroprusside. This is all what you need to know about pheochromocytoma. Pheochromocytoma is also known as chromophenoma. Remember the 10% rule. Remember, when you give alpha blockers, then beta blockers, 10% is extra adrenal, and the region is a sympathetic chain, which is also known as organ of Zucker candle. The next topic I would like to talk about is carcinoid tumor. Now, carcinoid tumor or syndrome. Now, basically what happens over here is that you can now see over here there is tryptophan, an amino acid. Now, usually tryptophan is it has multiple roles, as you all know, and one of the roles is to maintain the vitamin B3, so that there is niacin. Now, what happens in this tumor is that there is increased amount of tryptophan going to convert into serotonin, that is 5-HT, because serotonin and histamine is increasing, due to which now you will have the side effects of carcinoid tumor. Carcinoid tumor can happen anywhere. Okay, so carcinoid tumor, first of all, as I told you, serotonin and histamine is increasing. Why? Because of tryptophan. All the tryptophan is getting exhausted in the production of serotonin and histamine. Thereby, you cannot produce enough niacin, and the patient will start suffering from pellagra, which is vitamin B3 deficiency. If you talk about what are the symptoms you see, they are associated with the H receptors. As histamine is releasing, the H1 receptor, which will cause pruritus, flushing episodes, and H2 receptors is going to cause acidity because it acts in the stomach. Airways, asthma-like symptoms, so because there will be bronchoconstriction. Okay. If you ask you what is the workup, obviously because the pathway is going towards the production of serotonin, so that is why 24 hours urinary a middle product, that is hydroxyindole acetic acid, which is 5-HAA, that is going to be the workup and investigation which you have to do. That is 24 hours urinary 5-HIAA. What is the imaging modality? As I told you, it can happen anywhere, so that is why you need something which can detect any distant area. That is going to be PET scan. If they'll ask you the most common location, the most common location is going to be the bronchus. And if they will ask you the most common location in the intestine, remember, most common is going to be ileum, followed by rectum, and the least, this is a previous PYQ question, is going to be tip of the appendix. The drug of choice for your carcinoid tumor, remember, C for carcinoid tumor, C is for cyproheptadine, okay, which is a 5-HT antagonist. You know that 5-HT is increasing, so block it. So you give a cyproheptadine, okay. The next condition I would like to talk to you about is Cushing syndrome. Cushing syndrome, in which everything is in excess. That's why this is also known as hypercortisolism. Now, basically what happens is Cushing syndrome is increased. Now, what can be the causes? Number one cause is, first of all, exogenous steroids. Maybe because of some disease, maybe because of some RA or some autoimmune disease that you're giving too much steroids. That is why you develop Cushing syndromes. That is, so whenever you give it from outside or whenever you give it for intention of a medical condition, that is known as iatrogenic. Other condition is maybe if there is a tumor, ectopic ACTH production, because ectopic ACTH production can be seen with respect to carcinoid tumor. It can produce, or you can see oat cell cancer, which is small cell cancer of the lungs. They are basically paraneoplastic syndrome. Pituitary adenoma. Pituitary adenoma also thereby, because pituitary adenoma further with respect to the hormones is going to secrete ACTH, and further it will go and give symptoms of Cushing syndrome. Now understand one thing, there is a difference between Cushing syndrome and Cushing's disease. What is the difference? First of all, what is a syndrome? A syndrome is a group of symptoms together, right? And a disease is a particular entity. Now, the difference between Cushing syndrome is a broader term. Within Cushing syndrome, one of the causes of Cushing syndrome is Cushing disease. And how is Cushing disease formed? Cushing disease is because of pituitary adenoma. It is because of pituitary adenoma. Very important thing you need to know. Okay. So pituitary adenoma, it causes ACTH production. Thereby, it will be causing you Cushing disease. So make sure you know the difference between syndrome and disease. Other cause of Cushing syndrome can be adrenal adenoma. Again, everything will increase. The basic matlab of Cushing syndrome is hypercortisolism. Anything which is causing increase in the level of the layers of the cortex. Okay. So what are the defects? The first thing they ask you is what is the earliest sign of Cushing syndrome is, that is the loss of diurnal variation. Now basically one thing what you need to know is the cortisol levels throughout the day is different. It is going to be highest in the morning and least in the evening. So this diurnal variation is lost in Cushing syndrome. You can see it is like a straight line almost like this. So this is the earliest manifestation, that is going to be loss of diurnal variation of the cortisol. What are the symptoms you will see? Because obviously there will be weight gain, right? Along with weight gain, you'll have moon faces. The neck circumference will increase, because of which there will be breathing difficulty. So patient will snore. So that's why the patient can suffer from obstructive sleep apnea syndrome. The patient will have central obesity, but muscle wasting will be there around the limbs. That is why this is classically known as lemon on stick appearance. Okay, so you'll see they'll have purple classic striae which will be seen in Cushing syndrome. So colored striae, a buffalo hump will be there, fat deposition, abdominal stretch marks will be there, pedunculous abdomen will be there. These are the few symptoms which you need to know for Cushing syndrome. Okay. Now, along with this, what are the signs which you find out? Patient suffers also from hypertension. Why? Because of increase in total peripheral vascular resistance. As I told you that cortisol is responsible. If there is too much cortisol, there will be too much sugar. That is why people from Cushing syndrome will suffer from secondary diabetes. Cortisol is also responsible for activation of INAC channels, the one which aldosterone also is acting. So what does INAC channels do? It basically causes intake of water and sodium. So because obviously now sodium is also going to come inside, that is why hypertension is going to be there. But potassium and proton, which is H plus, is going out. That is why people who are suffering from Cushing syndrome will also suffer from a metabolic condition, that is hypokalemic metabolic alkalosis. One thing what you need to know is that ACTH is kind of similar to melanin. Why? Because the origin which is there in the within the brain, in the hypothalamus, has a common origin, due to which if ACTH is increasing, you will have melanin-like symptom, which is going to be pigmentation. So patients with Cushing syndrome will also have hyperpigmentation around the palm, the soles, the axilla, growing, and the gingiva as well. So these are the symptoms which you need to know about Cushing syndrome. What is the workup? Obviously, as your cortisol is increased, so you will have a 24-hour urinary cortisol level elevated. You will have another overnight test, that is known as overnight dextromethasone suppression test. Overnight dextromethasone suppression test. The investigation of choice for Cushing syndrome is low dose dextromethasone suppression test. Now, why are the multiple imaging you can see over here? MRI head to find out whether there is pituitary adenoma. Remember, pituitary adenoma will cause Cushing disease, right? HRCT test, why? For ectopic ACTH. Maybe it can be because of oat cell cancer, or maybe it can be because of carcinoid. You can do a CT abdomen to find whether there is an adrenal adenoma, right? Plasma ACTH levels can also be elevated. What is going to be the treatment? If a patient is suffering from iatrogenic caused related Cushing syndrome, slowly taper the dose and stop these steroids. If you stop the steroids all of a sudden, now the body is already accumulated for a high dose of steroid, all of a sudden you will stop it, the patient can go in Addison's crisis, adrenal crisis, which means severely all the functions are going down. Role of cortisol will go down, hypoglycemia, role of aldosterone will go down, patient will be suffering from hypotension, which is a medical emergency, and patient can also die. So make sure you stop the drug slowly. You can use drugs like steroid sparing agents. Now these steroid sparing agents reduce our requirement of use of glucocorticoids, which can be cause of Cushing syndrome. Drugs like azathioprine or mycophenolate, these can be also used. For the treatment of oat cell cancer, you have to give the chemotherapy, that is cisplatin and irinotecan. Okay. For the pituitary adenoma, first thing is that you can go for a transpenoidal surgery. If you are having an adrenal adenoma, the first management is going to be medical. That is and the drugs you have to remember. I remember in the mnemonic of CAM. Okay, so K is for ketoconazole, mitotane, metapyrone, and aminoglucothione. Okay, so these are the ones which you have to remember. This is known as medical adrenalectomy, followed by which you, once the size is reduced, you can remove it with the help of laparoscopic surgery, with either if it is a unilateral condition, so unilateral adrenalectomy. Okay, so this is all with respect to Cushing syndrome. If you have a case over here, a patient has a history of too much weight gain, hypertension, oligomenorrhea, and acne. Now see, three of the signs over here gives you a thing that it can be Cushing syndrome, but oligomenorrhea over here, along with acne over here, it satisfied 2 out of the 3 criteria of the Rotterdam criteria. So the patient is basically suffering from PCOD once you did the ultrasound as well. So make sure in the examination that you see the details, you understand, and don't like if you have one imagination, okay, this is most probably the likely diagnosis. The other options B, C, D, understand why these are not the options, because the main thing about the examination is that they know that you know the answer. They're trying to trick you out. So make sure calmly before every exam or before every MCQ, just take a deep breath so that your mind is calm, and then you do the question. The next disease which I would like to talk about is Conn syndrome. Conn syndrome is also known as primary aldosteronism. So basically what happens, a tumor is there that is present in the glomerular layer, due to which aldosterone is increasing too much. Now, what is the role of aldosterone? Aldosterone is maintaining the postural blood pressure. Aldosterone acts on the INAC channel, correct? Now, if aldosterone is going to act on the INAC channels, there is going to be reabsorption of water and salt. Because there is too much absorption of water and salt, patient will suffer from hypertension. Along with this, there is exchange of potassium and hydrogen which is going outside. So patient will also suffer from hypokalemic metabolic alkalosis. This is simple. I hope you understood the logic. Now, how will you do the screening of this condition? The screening is going to be by a ratio that is known as aldosterone-renin ratio. So the aldosterone-renin ratio is, you just in the numerator is aldosterone and renin is going to be down. Now see, whenever a patient is suffering from hypotension, the kidney goes and activates the RAS, that is renin, angiotensin, aldosterone system, correct? But if you notice over here one thing, the blood pressure is not rising because the patient already had hypotension. Aldosterone is more. That is why hypertension is there. Now your body already knows that there is too much blood pressure, so it will be sending a negative feedback to the RAS mechanism. So because of the negative feedback, you will notice one thing, that everything, the renin also will be low and angiotensin also will be low. So if you see the ARR, the aldosterone is elevated because of the tumor, but the renin, because of negative feedback, is low. So overall the ARR is going to be rising. Okay? You know that there is a tumor over here. So for the tumor, you have to remove it. So if they will ask you one more thing, that this is what type of hypertension in Conn's disease, because renin is low, this is known as low renin hypertension. Very important, low renin hypertension. Investigation, as you know that salt is increasing, so you'll have salt loading test. Before your operation, you have to remove the tumor. Before operation, you need to have something which is going to block the aldosterone action. That is going to be spironolactone. Okay. What is this classic side effect of spironolactone? You remember? Gynecomastia. Okay. So pre-op, to reduce the hypertension and to control the hypokalemia also, you can give spironolactone. Once the BP is controlled, proceed with unilateral adrenalectomy. Another condition similar to Conn's is known as Liddle syndrome. Now, what is the difference between Liddle syndrome and Conn's? In Conn's, there was a tumor. That tumor was causing increase in aldosterone, and aldosterone further was going to cause acting of INAC channel. In Liddle's, there is no role of aldosterone. Gain of function of INAC channels. Apne aap, by on its own, the INAC channel is functioning too much. Because it is functioning too much, it is reabsorbing too much amount of salt and water, because of which patient is suffering from hypertension. And the patient, with exchange of water, there will be exchange of potassium and a proton. That is why the patient is also suffering from hypokalemic metabolic alkalosis. Over here also you notice one thing, that since the blood pressure is increasing already, the RAS mechanism over here, the RAS mechanism will give a negative feedback. But over here you notice one thing, the ratio, the ARR ratio is going to reduce. Why? Because see, the ARR ratio stands for aldosterone divided by renin, right? In Conn's, aldosterone was already high, but renin is low. Over here, aldosterone is already low because there is no role of aldosterone. There is no tumor producing aldosterone. That is why, because of the negative feedback, aldosterone is also low, renin is also low. And in Liddle syndrome, ARR ratio is going to be low. That is how you differentiate between Liddle syndrome and Conn syndrome. Over here, the treatment is going to be that you have to control the INAC. An INAC blocker is known as amiloride. Okay, the INAC blocker is known as amiloride. So just to give a differentiation, this is how you study actually, doctors, that whenever you're having two diseases which are relatable, always in the next slide, you just give a comparison so that later on, you never forget, because these are very similar. See, Conn's, Liddle, everything, all the symptoms are same. But the defect is one is having an aldosterone problem, one is having an INAC problem, right? Conn's is a tumor problem which is causing aldosterone. Liddle's is a gain of function of the INAC channel. Symptoms all are same. The difference is the ARR ratio. The ARR ratio in Conn's is elevated, whereas in Liddle syndrome, it is going to be low. The treatment for Conn's is, first of all, you have to control the BP by giving an aldosterone blocker, okay, and that is going to be spironolactone. And for the Liddle's is going to be an INAC controller, that is going to be amiloride. After this, we would like to talk about Addison's disease. Addison's disease is known as hypocortisolism or cortisolism. Cushing syndrome was hypercortisolism. Addison's is basically adrenal insufficiency. It can cause adrenal crisis. What are the common causes of this is, first of all, autoimmune. Apne aap, it is going to cause the destruction of the adrenal glands. It can be because of histoplasmosis or disseminated TB as well. Now, basically, Addison's in simple way is that all the functions of the adrenal gland are stopped. The glomerular is not working, the fasciculata, the reticularis, nothing is working. So now we will be talking about what are the symptoms. Since aldosterone is not working, first of all, hypotension will be the patient will not be able to maintain the blood pressure. Salt retention is not there. That's why the patient will start craving for salt. Cortisol is responsible for the glucose maintenance. If cortisol is low, patient will start suffering from hypoglycemia. We discussed this in the first slide. Remember, hypoglycemia, the symptoms will be palpitation, irritations. Patient can go to coma also because of the lack of sugar which is being there, and multiple other signs. Okay. Sex steroids are not there. Patients, even classically, you will see loss of pubic hair, loss of axillary hair, voice changes, all can be there. Now, since all of this is there, this is happening in the adrenal gland, and our brain has already signaled that okay, the adrenal gland is not working. How does your brain stimulate the adrenal gland? By secreting ACTH, right? So since ACTH is going to increase, eventually, even though there is no use, because there is no functioning of the adrenal gland, still your brain, for sending a positive feedback, is going to send ACTH. And as I told you, ACTH has a similarity with melanin, so patient will suffer from hyperpigmentations on the palm, sole, on the axillary area, groin area, in the gingiva and the tongue as well. How do you do workup? As I told you, ACTH is going to be so much, so you're going to do an ACTH stimulation test. This is also known as cosinotropin test. The ACTH stimulation test is also known as cosinotropin test. The CT imaging will be finding, you'll see bilateral adrenal damage is there. The drug of choice for Addison disease is going to be hydrocortisone, because hydrocortisone has both roles, mineralocorticoid role and glucocorticoid role as well. Mineralocorticoid, aldosterone, it maintains your blood pressure, it is responsible for fluid level control, while as glucocorticoids is responsible for the immune responses, inflammation, and along with that, metabolism as well. If a patient is only suffering from hypotension, you can give flordocortisone. If the patient is only suffering from hypoglycemia, you can give dexamethasone. Okay. If I'll give you a comparison between Addison's and Conn's, Addison's can be autoimmune, can be because of histoplasmosis or disseminated TB. Conn's is a tumor causing increase in aldosterone. In Addison's, aldosterone is less, so hypotension. Conn's, aldosterone is more, so then there will be hypertension. In Addison's, you will have hypoglycemia, loss of hair, pubic hair, and stuff like that. Addison's, the test which we are going to do is ACTH stimulation test, also known as cosinotropin test. Conn's, the test is going to be a salt lowering test. In Conn's, ultimately you have to do a surgery, but before that you have to control the blood pressure. For that you will give an aldosterone blocker that is known as spironolactone. In Addison's, the drug of choice is going to be hydrocortisone. So this is all what you need to remember with respect to adrenal gland and its disorders. Make sure you understood each and every line, because each and every line is a PYQ. Around 40 to 50 PYQs have, 50 questions have been discussed so far. And if you like my video, please share and please like and please subscribe the channel, because it takes a lot of effort to make such videos. Take care and see you in the next slide.